Hi, everyone. My name is K Antwiler. I am a family medicine trained physician, and I am doing my fellowship in addiction medicine. So the addiction medicine fellowship actually takes place at Eisenhower, and we're also partnershiped with the Betty Ford Center, where we get some residential training. So I'm very excited to be working with the LGBTQ Center to be giving you all some more information and guidance in regards to methamphetamine use disorder. And as we know, methamphetamine is very popular. It's a very common upper, and I want to be able to give you guys guidance, support if you yourself or might be suffering from the disorder, if you know anyone who might need some guidance. So hopefully you'll find this lecture really helpful. All right, let's get started. Okay, so what is methamphetamine? I mean, by now, everyone knows what methamphetamine is. I mean, if you don't know, please tell me where that location you're living in. But it's a very powerful stimulant. It affects our central nervous system. The majority of methamphetamine nowadays is very illegally produced. It's illicit. You guys might have watched the TV show Breaking Bad. It's done in like very secret labs or kind of areas that are not really legal. Nowadays, because of methamphetamines as an illicit substance, the DEA has made it a Schedule II controlled substance. So technically, methamphetamine actually can be prescribed. It's known as digoxin, but primarily it's being used for ADD or attention deficit disorder, but it's not a very common treatment for it. Most of the majority of methamphetamine use is basically recreational or illicit use. So common street names for meth. I mean, we've all probably heard of it. Speed, crystal meth, just the way it looks like. It has this crystal-like formulation to it. That's why it's also known as ice, glass, crank, tweak, likely coming from the term tweaking, yellow barn, stovetop. These are all different names that kind of come over the years to define methamphetamines. If you hear this, they're likely talking about methamphetamine. The two more common things to kind of know from for street names is that crystal or ice, that's the highest purity of meth. So you have about the 94 to 96% concentration of the meth. Now the regular meth, so that's like more of the powdered form, it's only 50% pure. So that's why people like to use crystal meth. It's like the most highest, it's the purest form. It gives the most euphoria in a way. And what are the different types of ways you can use methamphetamines? So most of my patients nowadays, the most common way they use is to smoke it. And it's very quick. It takes about 6 to 8 seconds to kind of get into your bloodstream and go into your brain to get that nice euphoria effect. Another common way to use is intravenous use. Not as quick, but still quick, 10 to 15 seconds to kind of get to your brain. Intranasal, a little bit longer, so it's about 3 to 5 minutes. And then oral, I rarely hear of people using methamphetamines oral. It takes about 3 hours for it to go into the bloodstream and then kind of get into your brain. So most commonly what I'm hearing is people smoke it these days. Just to kind of give a history of stimulants, believe it or not, methamphetamines have been there since the late 1800s. So it was first created as like to help with depression. In 1932, there was an actual prescription methamphetamine that was prescribed. There was an inhaler and tablets that were released. And then in 1937, the American Medical Association actually approved amphetamines for depression. And that's actually sometimes very rarely used nowadays. If someone's having very refractory or treatment-resistant depression, there might be a few cases that might be using amphetamines for depression, but we've definitely come away from that sort of thinking. In 1939 to 1945, methamphetamine and amphetamines, they were actually used as like pep drugs to kind of keep, soldiers awake, to prevent them from being fatigued, from being crashing. So it's very commonly used between that time period from like the late 30s to the mid 45. And even the Germans were using it for their like soldiers. And then in 49, 50, the amphetamine, they become generic, and then they're basically being released as antidepressants. Around the 1960s, that's when it kind of gets a little bit more into the recreational and illicit use. It starts to infiltrate the motorcycle gangs, and different types of little laboratories, clandestine laboratories, are being created. And then from 1970 to 71, the government kind of takes control, and the DEA kind of plays a part in this, and they make it a scheduled medication. So you cannot get it without a prescription. And in the 80s, ice, which I was telling you all about a little bit earlier, the purest form, that becomes super popular just because of the amount of euphoria and everything you get from it. And kind of similarly around this time, HIV also gets popular, and people start to get more information about that as well. In the 1990s, that's when the smuggling takes place. So Mexico kind of plays a role into it. There are being super labs are being created, and the government is trying to crack down on who is smuggling this meth and where exactly it is coming from. And then by the 2000s, the methamphetamine, the purity just keeps getting better, but the price is no longer a problem. It's super cheap now. So if anyone's looking for it, they can pretty easily get it. So that's just kind of like the timeline as to how meth has kind of evolved in our country throughout the years. So how does meth work? Like, why do people use it, and what exactly is happening from a neurobiological standpoint? The basic, very easy answer is when someone takes meth, there's more dopamine, more serotonin, more norepinephrine being released. The meth, it goes into our the neurons and the synaptic areas of our brain, and it works on those receptors that more and more of the dopamine, serotonin is being released. So if you can take a look at this picture right here, I know it looks like a lot of little Legos are being like thrown around here, but the yellow bar is basically amphetamine or methamphetamine. And you can see it's working in this little circular area. And the green little Legos, they're norepinephrine, catecholamines, they're just being released into the body. And on the same side, you can see the gray little Legos, again, more dopamine is being released into the body. At the same time, the meth also works on the dopamine transporters, and it works on the transporters in a way that it prevents the dopamine from going back into the cell. It's keep on pushing that dopamine and serotonin to go into the bloodstream. So you're getting like this explosive amount of dopamine and serotonin that basically gives you this great feeling. And the thing about methamphetamine is that it's lipophilic, so it likes to kind of go through the fatty tissue, so it more easily crosses through to our brain. And it has a half-life of 12 hours. And I have a little video of the mechanism of action, and if we have time, I'll make sure to play that video for us. Okay, so this diagram just basically illustrates why people who use meth can want it, or in a way develop a disorder to it. So looking at this diagram here, this basically tells us how much dopamine kind of comes out from certain things. So we're looking at food. You know, people like to eat. You know, I'm a foodie. I get pleasure from eating food, and that gives us a dopamine amount of 150. That's pretty good, you would think. Now let's look at sex. Sex is also another great way, you know, to feel good. It's something that people enjoy, and it's a natural pleasure of life. Sex gives a dopamine output of about 200, so a little bit more than food. So, you know, that's understandable. That's maybe people like to eat and then, you know, maybe engage in sexual activity. Now let's go to the opposite side. So, and when we look at amphetamine, now that dopamine output is about 1100. So we're going from basically 150 or 200, which you get from food or sex, to 10 times that amount of pleasure from meth. So one can only wonder, when you get that kind of euphoria, that kind of sensation, that 10 times amount of pleasure you can get from food or sex, no wonder it can be so addicting, 10 times the amount. So I want that to kind of, go in your head. And then cocaine, high, yes, it's about a little bit less than 400 of dopamine amount, so 4 times as much as food. And then nicotine, kind of around, you can say it's like a little bit like in the 400 area. And even morphine, still kind of like around the 400 area. So that this itself kind of tells us as to why amphetamines or meth can be so addicting. Like a 10 times amount of food pleasure you can get if you get from meth, no wonder people want that. So this is just an idea to understand why people, use meth and why it's a very hard cycle to break. Okay, so what are the symptoms we kind of look for when maybe a patient or a person is intoxicated versus when a patient might be withdrawing from methamphetamine? So when someone is intoxicated, they get that feeling of such a nice feeling, euphoria. When sometimes some people who drink coffee, they get this like increased energy, they're more mentally alert. They get that from meth, but 10 times as much. Their appetite is decreased. So sometimes people who are wanting to lose weight, they sometimes use meth. Sometimes with intoxication, they can have other symptoms which are not the pleasant ones. So they could have like increased activities like skin picking, teeth grinding. We'll go a little bit more into this. This is kind of like the complications, but they can start thinking things that are not there, seeing things that are not there. Their heart rate goes high, their blood pressure goes high, and they're more risk-taking. They're more confident. They're more involved with their hypersexuality. They're not fearful. And kind of going with a negative thing, they can also be agitated. And we'll go a little bit more in depth into that. And then there comes the withdrawal side. So people are more sad. They're a little bit dysphoric. They're not interested in doing anything. They're super tired. You might have all have heard of the meth crash. They just don't want to do anything, lethargy, irritated. They're also hungry during this time. So whatever they did to not eat, they're going to make up for it. And then more slowing of the activity. So they're just going to walk slowly, talk slowly, not really interested in engaging. So very different presentations when someone who's actively intoxicated versus someone who is withdrawing. So meth intoxication, that's like a whole stage, which I want to guide you all through. So first, that rush, when someone uses the meth, that nice alertness, awake, they feel super smart, they're motivated, they want to clean their room, they're ready to kind of get through with their life. They have the self-confidence, they feel like they're 10 out of 10, they're amazing, and they get this amazing euphoria. And then that kind of goes into the high. So still you're having that euphoria, that sustained energy, that mental clarity, not really wanting to eat, weight loss. Now, this great feeling, people want to continue that. And that's what happens with the binge. People can keep going on this. So I have patients who can continue this constant binge for like a week, where all they're doing is taking meth and then engaging in sexual activity on and on and on. And then after maybe like a week or so, they kind of crash. So crash is basically what I was talking about a little earlier. They're just sleeping, fatigued, not wanting to do anything, irritable, just this period of like not doing anything. And then the worst phase of meth intoxication is basically known as tweaking. So it's a very common kind of term to use. And when someone's tweaking, that's when they are might be having paranoia, hallucinating. They're seeing things that are not there. They're feeling like maybe bugs are kind of crawling up their skin. They can't sleep. They're like in this manic phase, agitated. They feel like they don't know where they are. They're basically disconnected from reality. And they're scared. They don't know what's going on. So that is like, and this could lead into sometimes like a meth-induced psychosis. So it's the most scary part of meth intoxication, and patients can be hospitalized for this, and they would need medications to maybe calm them down and kind of get them back to their baseline. Oh, sorry, my hands are a little like butterfingery. Okay, so what's the problem? Why are we even talking about methamphetamines? So particularly in the MSM population, meth is common. It's 10 times more prevalent in this population. The annual prevalence, so how many patients or people are on meth, it's about 12 to 30%. So that's a significant portion of our MSM population that is using methamphetamines. And with our MSM population, there's an increased pleasure from sex, and we'll go a little bit into that. And just at like one circuit party, so basically these big parties where we, either the MSM or different populations they kind of go to, 43% of those participants said that they used meth. And the problem is that meth, it creates this loss of inhibition. It helps with weight loss. It makes a person more mentally alert. And these are all problems because, especially in our community, we have a little bit of the older folks. There's aging in the community. So there's something we kind of have to keep an eye on as well because of the complications of methamphetamines. Cost. So again, this is another issue as well. A lot of people that I know who use meth, they don't have to pay for it. It's just freely available, which makes it there's basically no barrier. It can be easily exchanged for sex. It's available at parties. It's cheap. It can be sold at like $20. And the recent studies show that the burden and the morbidity that come from methamphetamines, it's actually from impaired judgment of the person rather than like financial loss or a loss of job from the drug itself. So I have a tiny little picture here so you can see. So an ounce of meth is about the size of a baseball, so pretty big. And you can see like 28 of those right there. They're going for like a wholesale value of like $400. So basically at $50 per dose, the street value of meth, like an ounce of meth is it's just $2,000, $2,800. So it can be pretty cheap. Okay. And then coming to meth and sexual activity. So why is this more common in our MSM population? So with crystal meth, the sex is longer. People have a delay with their ejaculation, which a lot of times leads to those binging periods. But at the same time, a lot of people don't know because of that longer ejaculation or longer sex, it can cause erectile dysfunction. It can lead to an increase in Viagra use. And this loss of inhibition, people engage in rougher sex. So it can lead to more trauma to the rectal regions and to the penile regions. And this confidence, again, going back to the disinhibition, people who use meth have multiple partners. And sometimes that can lead to unprotected sexual activity, which can be a risk. And then again, kind of going to our older population here. Why are they using meth at 60 years old? So some of the comments I've heard from my patients or from people is, with crystal meth, it's the best sex I've ever had. I don't feel old. I don't feel invisible. I love my partner, but when we first met each other, shoulder pads were in style. And another like common comment to hear is, younger guys are actually interested in me now. I know it's the drugs, but when you're high on meth, it really feels real. So these are some of the common statements made by people who are 60 and older and what might be attracting them to using methamphetamines. So appeal for people living with HIV. So why is it common for patients with HIV to be using meth, or why might they resort to that? So a lot of people or patients with HIV have said that they still feel a lot of stigma sometimes. So when they use meth, they don't have to be worried about rejection based on what's going on. And a lot of them have felt burnout with safer sex. So sometimes they're tired of using condoms, or they're just tired of using their HIV PrEP. So when crystal meth gets involved, there's a lot of unprotected sexual activity, and sexual activity can also happen without PrEP, which can be dangerous. Okay, so it's important to identify recreational use versus an actual meth use disorder or a stimulant use disorder. So not everyone who uses crystal meth is going to become dependent or develop a disorder. So some people, they might not increase their use, but they can still have less sexual activity while they're using. Some people can go on for long periods without using, and they can just stop by themselves. But then there are others who can just like that develop an addiction. So it's very careful. So we have to be really careful in advising these patients and people and helping them realize that the amount of dopamine we can get, it can lead to a disorder. So what are some things we want to kind of look at for that might indicate, hey, this use is becoming a little bit more risky? So weekend use kind of goes into weekday use now. There is extended periods of heavy use. So the binges are getting longer and longer and longer. There is more sexual activity with the use. So what I mean by that is like more partners, rougher sex, more trauma to those areas, more intense sexual behaviors. And then patients who been diagnosed with HIV, they stop taking their antiretroviral medication, or others may stop taking their PrEP. And then another thing basically is not going to work, basically becoming intoxicated with meth or using meth, and then trying to cover that up and maybe leading to loss of job or getting like legal issues. So these are things that will warn us saying, this is becoming riskier and riskier. So just to give an idea, a lot of times people don't realize how big meth can be in terms of causing complications or hospitalizations, especially now with the fentanyl epidemic. Everything, all illicit substances can be laced with fentanyl. So meth, cocaine, benzos, Ativan, Xanax, they can all be laced with fentanyl, and a person who uses can suffer an overdose. You can see here, so from 2003 to 2015, there's been a huge rise in amphetamine-related hospitalizations. So basically in 2003, there were about 40,000. Now it's tripled. It's 120,000 hospitalizations being related to methamphetamines. This itself is slowly developing into its own little pandemic. And that's why we have to be wary and cautious of what's going on with methamphetamines in our country. And as you can see, the West is kind of taking the lead compared to our Midwest and South and the Northeast regions. So coming to a little bit about the complications of methamphetamine use. So starting off with the neuropsychiatric consequences. So the same way where how meth increases the release of neurotransmitters, it increases dopamine, serotonin, our catecholamines, that also has a negative part to it. So when there's more catecholamines, more norepinephrine, epinephrine that are being released, that puts a higher risk for strokes, for seizures, for hyperthermia. And with this increased amount of serotonin and dopamine that's kind of going into our brain, that's just too much for us, that's where it leads to psychosis. So we can basically hallucinate, have like delusional thought processes, basically have problems with the way we think, which is very scary. And then this chronic use, so this chronic increase in dopamine, serotonin, and norepinephrine, it actually causes damages to our nerve terminals. And how that can present, patients can have problems with like movements of their hands, with typing, grabbing items, basically fine motor movements can be affected. And There's also impairments in just cognitive functioning. So people can have problems talking, but like executive function, they might have difficulties doing their activities of daily living, maybe taking care of their finances or cooking or using the toilet. And it also causes problems with memory. So patients or people might suddenly have episodic kind of losses of their memory, and are confused as to like, what's happening? What is going on? And I just wanted to put a picture here of the way meth affects the brain. So you can see on the right side, there's a brain of like a diagram of an Alzheimer's patient. And you can see the red area is basically kind of loss of the brain matter. So you can see decay all in that area. So an Alzheimer's patient, a lot of times they're a little bit more older. So we can say maybe 60 and above. And this is what their brain is looking like when Alzheimer takes place. Now, someone suffering from methamphetamine use disorder, you can see on the left side, they have the same kind of brain decay that's going on in the same region. So if you think about it, so patients who suffer from Alzheimer's, they have memory issues, they might have problems just like, walking, cognitive things. Those are the same things that could happen to a person who's using meth, and they might be half that age, 20, 30, 40. So that's something to just think about, how scary using meth as a recreational drug. So meth doesn't only affect the brain and our behavioral health. It's a very common substance to affect the heart. So there are actually a lot of cardiac consequences that meth does, and this is very commonly seen in the hospital too. So like I previously mentioned, meth increases the amount of epinephrine and norepinephrine that's being released. Because of that, with that catecholamine increase, it actually causes a toxicity, and that kind of comes up in ways as chest pain, increased heart rate, increased blood pressure, and this undisputable amounts of catecholamines. It can lead to a heart attack. It can lead to like a tear in our aorta. And on a chronic basis, it can lead to coronary artery disease. And very commonly it can cause cardiomyopathy, which is basically heart failure. And it's a pretty common heart failure that we see in the hospital too. So patients or people who use meth, they have a 3.4 higher odds of getting cardiomyopathy. So meth kind of like affects like our huge main organ systems. Something that it is worthy to note is that patients who developed heart failure from methamphetamine use, if they stop using, and if they do have reach abstinence, there's a good chance there can be a improvement in their heart failure by about like 5 to 15%. So that's why we always recommend patients who are hospitalized with heart failure from meth. We tell them it's not too late. If you are able to embark abstinence, there can be improvement with your clinical diagnosis. And just to kind of go through other complications, so we touched on memory deficits, dental decay. So you all might have heard of the term meth mouth. So that's because of decreased saliva, the grinding of the teeth. And when they're using meth, they want to take more sugar. So that all plays a role with like dental caries. And then like skin picking, so they can get like something known as crystal bumps, or if you're using IV, like skin popping. And then we touched on erectile dysfunction. It can cause muscle wasting. And then finally, very important things, it can affect, your relationships, your romantic or family, and it can affect your occupation, your finances. So it affects your whole living and your whole being. So there's a lot of crossover between meth and hepatitis C. So when people are using meth, they can be injecting, which is also known as slamming. We kind of talked about the traumatic sex. They're like sharing bumpers, straws, they can be snorting. So when this is happening, there can be an increased risk for getting hepatitis C or HIV. And there's also studies showing that when there's a combination of crystal meth use, diagnosis of hepatitis C, and HIV, there's an increase in cognitive deficits and cognitive issues. And also, when someone's using crystal meth, they might not want to keep getting their treatment for hepatitis C. They might stop being compliant, stop going to their doctor's visit, and they're basically back to being square one, where with hepatitis C, if they get treated, they get treated. There's a cure. Okay, so how do we address this? So how can we kind of take care of this from a clinical standpoint? So when you're seeing your primary care doctor, you sometimes have 15 to 20-minute visits, and it can be hard. You can't solve all the problems during that time. One of the main things we as addiction medicine providers do is that we don't want to argue with the patient. We want to work with your goals, your motivation. You are the captain of your ship. So even though we have patients who might be ambivalent, might not really care about their methamphetamine use, we always kind of tell them what the risks are. We guide them and we tell them that we're there for them. We also tell them that relapse is common. It shouldn't be thought of as something negative. I mean, addiction is a disease, and it's a chronic relapsing disease, and that's how we tell our patients. And we as providers, we understand that our agenda might not be the patient's agenda. So we are ready to work with the patient, and we do. And another important thing is we understand that patients will hear what we say, but they'll make that move when they're ready. So we will keep motivating them every visit. So another important thing I wanted to highlight about methamphetamine use. So we kind of talked about the neuropsychiatric complications of methamphetamine use. So basically, when you keep using meth, the dopamine goes down, the metabolism goes down, the amount of dopamine transporters goes down. But what I didn't mention is that with a good amount of abstinence, so about maybe like around the 12-month, 14-month abstinence, someone who stopped using meth, they can actually recover from that hit. So if you look at this MRI imaging right here in a healthy person, you see these like red spots. So that's basically the dopamine activity that's the receptor activity, transport activities going on. And then when you see in the picture a little bit to your right, this is a person who's used meth and they've just recently gotten abstinence for 1 month. They don't have that dopamine activity anymore. They're devoid of it. But when you look down there, with 14 months of abstinence, that dopamine transporter and metabolism has recovered. So this is another great thing. There is a great chance of reversibility and improvement with health if a person can become abstinent. And this is a very positive and motivating factor. So the basic premise of our treatment and of my addiction medicine clinic treatment is harm reduction. How can we make sure we can lessen the amount of harm in a way that makes the patient happy and it provides a good rapport between the provider and the patient? So a lot of the patients that come in, they're not ready to stop, but they're willing to come in, they're willing to engage in care, trying to kind of keep an open mind. So we want to ask them, what is their bottom line? What do they see as their ultimate bottom? And what would make them think that they have a problem with methamphetamine use? So we would just motivate them, kind of let them understand, talk, see what thoughts they might have about it. Because sometimes when you give patients the time to think about it, they might understand maybe my life will be better without methamphetamine use. So we also teach basic things. So when someone's using meth or maybe going on binges, they might not hydrate themselves. They might not eat. So we tell them, keep yourself hydrated, eat more, so make sure your teeth are clean. So use fluoride rinses, use sugar-free candy gum because there's an increase for sugar intake. And then we also recommend using clocks or timers. So when people who go on binges, the binges sometimes can last anywhere from like 48 hours to maybe like 7 to 8 days. So what I would recommend my patient to do is if they're going to be engaging in sexual activity with meth, I would tell them, hey, put a timer on maybe for like 1 hour or 2 hours. So that's a physical reminder for you to stop at that time when the clock rings, and then walk around, drink water, eat. So it's like a stop. It's like a mental stop to the binge. And then basically kind of talking about how to use their medication. So making sure if they're already on PrEP, making sure they're compliant with their PrEP, or maybe getting them on PrEP, or being compliant with their HIV medications. And the other thing is making sure they're getting their screening for sexually transmitted infections. So syphilis, HIV, hepatitis. So we want to make sure our patients get that screening. And then we all, teach them on safer sex practices and even serosorting. So serosorting would be having concordant partners. So if someone is HIV negative, we recommend them to have partners that are HIV negative. So coming on to the pharmacotherapy or the pharmacological modalities that are available for methamphetamine use disorder. So the two medications that have the most guidance and are the most research is bupropion with or without naltrexone, better with naltrexone. You guys might have heard it with its brand name Wellbutrin. It's a very common antidepressant. And the other medication is known as mirtazapine or Remeron. So when bupropion, so naltrexone is an anti-craving medication. It's commonly used for alcohol use disorder. It can also be used for opioid use disorder. So when the combination of bupropion and naltrexone is used, bupropion in a way kind of mimics the way dopamine is being released. That's the way it kind of works as an antidepressant. And naltrexone kind of blocks sometimes that dopamine release you get from meth use. So that combination therapy has been shown to be very helpful as an anti-craving agent for patients who suffer from methamphetamine use disorder. And some benefits that come from that combination medication is that it's actually now FDA approved for weight loss and appetite suppressants. So patients who might be using methamphetamines to reduce their weight or to kind of reduce their appetite, this would be a great option for them. Another thing is that bupropion, it's a little bit activating. It's a little bit more adrenergic. So patients who use meth to kind of get that kick in life, to get that morning start, might do well with the bupropion naltrexone combination. So the dose that the bupropion works is 450 milligrams. So the common doses are maybe that are used for depression are like 150 or 300 milligram. So we work closely with our patients. So we start them off at a low dose and slowly titrate them up until they reach that target dose of 450 milligrams. And the best evidence is shown that when it's being used with naltrexone. Now, the great thing about naltrexone is that it can be an oral medication that you can take along with your bupropion. And there's also an injection version. So the Vivitrol, which is the long-acting naltrexone, it's an intramuscular injection that basically goes into your buttocks. Very safe, very easy. We do this all the time in our clinic. Patients love it. It's one less pill for them to take. And I'll show some graphs on the benefits of it, but this combination therapy has been very useful to help reduce methamphetamine cravings. And I actually had one patient who's currently on this regimen, and they told me that when they think about methamphetamines, it actually makes them nauseous. They don't even want to use the meth. Certain things you kind of want to keep in mind with bupropion is that it's not the safest for patients who have seizures because it can reduce that seizure threshold. And it's also not safe for someone who has an eating disorder because they're also at a higher propensity for getting seizures. So for those kinds of patients, we do not recommend bupropion. But it's great when you have ADHD because it's also activating. It's great for depression. It's also a treatment for nicotine use. So overall, a very great medication if you don't have seizures. The next medication which is also beneficial, is known as mirtazapine or Remeron. And it is also an antidepressant. It's also an antidepressant. And it kind of works similarly to bupropion. The main mechanism of action for both of these medications is to increase the amount of neurotransmitters that are being released. So with mirtazapine, it's a little bit more release of serotonin that's going on. Now, this is a great medication if a patient is having sleeping problems because of the meth intoxication or the meth psychosis. They're not able to sleep. They're constantly moving around. This can be a great option for them. It's also great for depression. It's great for insomnia. It's also great for patients who might not have an appetite. So which can be a good or bad thing. So for patients who don't want to eat or their BMI is really low, this will increase the appetite, increase them to gain weight. But for the patients who maybe don't want that, then bupropion would be a better option. So both of them are pretty safe medications. With the mirtazapine or the Remeron, the target dose is 30 milligrams. So again, when a patient comes to our clinic, we slowly start them off at a low dose, monitor how they do, and eventually we'll get them up to the higher dose of 30 milligrams. These are the two medications that are being used pretty widely. I just wanted to put the other three that are there, but there's not much evidence or guidance on these. So methylphenidate or amphetamine. So the idea is that there might if there's an underlying ADHD that's causing someone to use methamphetamines, then great, they can use stimulants to treat it. But if someone doesn't have ADHD, there's not much guidance or there's not much benefit that's been shown by studies just putting them on Adderall or Ritalin. Another treatment that's still being kind of considered is topiramate or Topamax, but again, there's not much good studies to it. It also has other side effects like mental clouding. It can make a patient more tired. It can cause kidney stones and electrolyte problems. So the two top treatments for methamphetamine use disorder right now is the bupropion or Wellbutrin with naltrexone and the mirtazapine and Remeron. So those are the two that we're widely using in our clinic and in the hospital and in the residential centers. So this is just to, like I mentioned earlier, I want to show how beneficial the medications are. So this is just naltrexone, so one part of that combo medication of bupropion and naltrexone. You can see here, there's a significantly greater amount of negative urine drug tests as compared to placebo. So you can see the red line here. It basically kind of gets to, you can see maybe 30 samples, but with the naltrexone group, it's much higher. It's actually starts at 90 and and then kind of goes to 40, but still it's double the amount of negative urine drug samples as compared to the placebo group. So this shows that naltrexone is a very potent agent in helping control cravings and subsequently relapse. And Vivitrol is the injectable version of naltrexone, which I highly recommend because some patients might forget to take their oral medication. So this is basically in your system. It's an easy shot in the buttocks once a month. And again, you can see here, so the blue line is the placebo. And with the red line, you can see that there's a much higher quantity of people who are doing well. Oh, I'm sorry about that. Who are doing well on the Vivitrol injection. So there's actually medical guidance and trials which tell us that these medications are helpful in patients getting negative urine drug screens and kind of maintaining their cravings and prolonging their periods of abstinence. So there is treatment, because I know a lot of people who I see, they tell me, oh, I didn't know there's medications for methamphetamines. I didn't know there were medications to control my cravings for methamphetamines. So there are, and it's important that, people or your loved ones know this. So another modality of treatment, in addition to pharmacotherapy we use, is known as positive affect intervention, or it's also known as contingency management. So basically, the basic premise of this is motivational incentives. So what do we do here? What is contingency management? We want to reward the patient for basically like an accomplishment or good behavior. So one example is when a patient comes to the clinic, we talk to them, we get them started on treatment, and the goal is basically to maybe not use methamphetamines when they come back. And when we see them on their subsequent visit and they haven't used methamphetamines, we give them a little incentive. We give them maybe like a $20 gift card or a $25 gift card just to motivate them. It's not a lot, but it's like a nice positive reinforcement in patients that we're able to elicit desired behaviors from. Now, it doesn't necessarily have to be that they stopped their methamphetamine use. So for example, like when I have patients who I see for the first time and I notice ambivalence, and I tell them to come back to see me in 2 weeks, just so we can develop that rapport and make sure we have that communication going. And if they come in, that shows me that they're motivated, and I give them a gift card. It might not be like a bigger gift card, but I give them a smaller gift card just so to show that, hey, thank you for coming. Thank you for being engaged in this treatment. Again, if I see a patient and they've reduced their methamphetamine use, the next time I give them a gift card just as incentive for them to be like, oh, this is a good thing. I am doing good behavior. And so these little things, these little goals that they achieve, I want to reward it. And this positive affect intervention, it is helpful for patients, and it helps them prolong their, whatever their goal might be. So if they're trying to get to like prolonging their abstinence or slowly decreasing their methamphetamine use or just getting them engaged in treatment, has been shown to be beneficial. So just to kind of reiterate what I was saying, so the positive affect intervention, we basically monitor what their behavior is. We give them an incentive when that target behavior happens, and we don't give, and then we remove that incentive when that target behavior doesn't occur. And there are journals and guidance which actually has done studies on the contingency management and how patients do, and the results are that in patients who are in the contingency management program, in addition to like the normal pharmacotherapy, in comparison to those who are not in contingency management, the patients who have been in contingency management have higher levels of negative urine drug screens, higher levels of abstinence period, and higher levels of retention rates. So it is a very beneficial type of therapy that should be used in treating patients with methamphetamine use disorder. Again, this is just kind of to give a visual of how important contingency management is. So you can see here that the regular treatment is in the blue line. And then when you give them the contingency management or that intensive treatment, there's definitely like a higher number of negative urine drug screens. So kind of like double. So you can see that this is beneficial to patients who come in for methamphetamine use. And again, a similar diagram. So you can see here with just regular old CBT or cognitive behavioral therapy, yeah, you get some negative urine drug screens, but with contingency management, it's almost double, without basically just by motivating the patient, by giving them little incentives, telling them that, wow, you did great, this is how we want to do things, motivating them. That like doubles the amount of negative urine drug tests. And then you can see, even when you combine therapy with contingency management, there's not much difference in the amount of urine drug screens. So this shows that this is a very important treatment that should be utilized. So this is my last slide. So coming into recovery. So we're very understanding. It's important when we want to understand if a patient is committed or if they're ambivalent towards their treatment. Our main goal is harm reduction. So we are always here to motivate the patients, even if they're ambivalent, just to keep reassessing it every time we see them, just to make sure, at some point that they understand that this might be deleterious for their health. And we as addiction medicine think it's very important to not only treat the person or the patient, but their whole family. So it's important to involve their partners, their spouses, parents, any family member that's involved, because addiction doesn't just affect the person, but it affects the whole tribe, the whole family. So it's very important that we're able to help family understand what's going on, what the treatment options are, and how best to provide support to the patient. And sometimes rehab is not an option for patients. It might be too expensive. Their insurance might not take it. So we really want patients who come from methamphetamine use disorder to make use of group therapies or just regular therapies. Go to like meetings, NA meetings, do like motivational enhancement programs, maybe even do like partial hospitalization programs where they live in a program for a little bit and do like meetings or group settings. And then finally, there are a lot of associations that are there to help out with methamphetamine use. So there is Crystal Meth Anonymous. Obviously, there's AA, which is very famous. There's NA. There are plenty of meetings throughout the desert. So if a person or patient is interested, there are a lot of programs with availability, even like Zoom or virtual programs that a person or a patient can attend. And then finally, there's a website that I just added. It's called tweaker.org. And if you need any more information, anything like that, that's available as well. And then thank you for attending my lecture today. Please feel free to email me any questions you might have, any concerns. If you just feel like you need someone to support you or guide you, my email is there. I've also put my clinic address and number in case you know someone who might need treatment, or if yourself are needing treatment, we are there to provide any help we can to provide motivation, medications, or whatever that high level of care is. We're there to support you. So please don't hesitate to reach out. And thank you all for your time today.
Wow, fantastic. And so many potential questions coming up, I'm sure. We do have one in the chat that is just, we'll start it off. It says, is treatment covered by insurance for most individuals?
So the medications like Wellbutrin and mirtazapine, Remeron, they're like any medication. So they're like antidepressants. So they should be covered by your insurance. Where it gets a little bit iffy is the long-acting naltrexone or the Vivitrol injection. That is a little bit, it can be a little bit iffy. It can be a little bit expensive sometimes with insurances. So that's something that's not always easily available. Sometimes the out-of-pocket cost could be $700. And if that happens, we don't need to worry about it. There's the oral version, and we put patients on that, and we even use a higher dose of the naltrexone if needed to kind of combat that inability to use the injection. But hopefully, we hope that insurances are realizing how important addiction medicine is, and hopefully further down the line that injection gets completely approved.
Fantastic, thank you. All right, at this point, everyone, please feel free to unmute yourself, be respectful of each other, ask a question of Dr. Antwiler, and let's kick off some nice, robust conversation here. I see someone, go ahead.
Hello, doctor. I was wondering if you can give partner and families some advice as to how to handle a long-term partner who has been apparently addicted to meth over the years, on and off, and has managed to stay undetected. But now looking back, I realized that he has not been able to hold down a job. He constantly lost jobs. He is in his mid-40s. We've been married. We've been together almost 20 years, and for the last 2 weeks, he stayed out 5 nights, all night, and now he refuses to come back, of course, saying there's marital issues. What advice would you give to us? Me and our son are at a loss.
Right. It's a very difficult situation. I understand, and I'm sorry that you're going through that. I would definitely have a talk with your partner, try to help see where he's coming from, see if he's able to understand the consequences, the health complications that are going on with meth use, trying to understand his point of view. There sometimes people feel maybe there's always an underlying reason for use. We don't know if he's depressed, if there's some anxiety going on, what that reason or trigger for his meth use might be going. A lot of times there's traumas in childhood that might lead to methamphetamine use going on. So my first thing would be to maybe have a sit down talk with him, try to understand why he's using, and see.
And that's it, doctor. You hit it right on the head. He was taken away from his natural parents at 4 and went from foster home to foster home to foster home.
Right. And as you probably can understand, that is so traumatic, and that can affect a person from inside out.
Yes.
And I think,
yes, ma'am.
I think a lot of times people, when we try to engage with their like traumas and try to get to know their core, they will feel like they're finally being listened to or finally being heard. So it's very important to have like I mean, of course, I would love to see him in my clinic. So if you're able to come to my clinic, one of the most important things is to kind of talk to him, try to understand where his use is coming from, maybe kind of tell him what the health complications can be. Sounds like he's a young guy. Just kind of go over whatever we kind of talked about and tell him, hey, at a young age, I don't want you to be having these health complications, and kind of see where he kind of goes with a scale of like if he is kind of motivated or if he's ambivalent, and see what meth is answering for him, or what is meth giving him, like what is it that solace or what is it that treatment it's giving him, so we can be able to substitute it with what is more healthy or what is more appropriate.
And doctor, if I could ask one follow-up question. Every time he has a binge or something and leaves, like I just described, it always comes back to me. I'm 17 years older, and so when I try to talk to him about it, he will always come back and say it's our relationship. It's I'm leaving and I'm staying out because of our relationship. Mm-hmm. But it's always the mess. It's always the mess. When he's not on it, he admits that our relationship is fine. And so even, me sitting through this, I want to talk to him, but I don't know if he'll even talk to me right now. What would your advice be about that?
I think sometimes maybe talking to him in a way of like, I'm a little bit worried about your health. Why don't we go and talk to someone who is objective, both of us, and you can tell them what's bothering you while you're using it. And you could be like, I'll just be a silent observer and see what's going on. It's going to be just about you, and let him take, the front fold and feel like, he's being given the center of attention, and maybe he can feel like he can help us understand what's going on. What I would recommend is, bringing him to like, it doesn't have to be to our clinic, but to like a therapy, maybe like a marital therapy, and just letting him explain what's going on. I mean, like I said, we can't expect everyone to be easily motivated to stop using meth. It's a gradual, like stepwise progression. So we can put like little seeds. So you can put little thoughts in his mind saying, hey, I'm just a little bit worried about you. Do you think maybe we can talk about this with another, like an objective person or a therapist, only because I care about your health, no reason. So he doesn't feel like there's some kind of like, I don't want to say malicious intent, but something where he feels negatively towards.
Okay. All right, doctor. Thank you so much.
Of course.
You have another question? I have a question,
please,
doctor. What, as I'm sure you know, meth in the gay community is a really big issue. And I'm wondering what evidence-based practices you're using at your clinic that have been studied with gay and bisexual behaving men versus how you've adapted standard EBPs.
I'm sorry, standard what? I didn't hear the last part.
Evidence-based practices.
Oh, I see. So a very common thing that's very easy that we tell patients who are part of the LGBT community is to use like I mentioned a little bit earlier, clocks and timers. So it's very hard to like expect a patient who's using meth to just tell them to completely stop. So what we want to do is a more like a harm reduction kind of approach. So we want to maybe like reduce the amount of binges or reduce the amount of meth that they're using. So we tell them to use like clocks. So we tell them before the activity starts, use a clock, keep it for like 3 hours. When that clock like plays its ringer, stop the activity, walk out of the room, don't engage in that behavior. That's one of the evidence-based like treatments that we use for one way. Another thing is definitely the medication. So there was actually a study that came about the two medications I talked about, so the bupropion and the Remeron, and they were specifically studied in the MSM population. And it actually showed the greatest benefit in MSM population. So I think it's more popular right now with the MSM population than with maybe the MSW or WSM.
Right.
And then again, there's the contingency management, but that's not targeted just for the LGBTQ population. That's just, like a generalized approach that is shown to be beneficial. But I would say those two medications have been well studied.
Yeah, actually they have. I've done a lot of work with Dr. Steve Shoptaw at UCLA around that. Are you guys drug Medi-Cal certified? Can Medi-Cal recipients come to your clinic?
We don't, unfortunately. We're trying to expand access in the next year. We're trying to get now, I think we're working on an IEHP patients to get in, but we're really working hard, and we would love to see all insurances, but it's just a little bit of a barrier at the moment.
Okay, if you need help with the certification process, you can call me.
Oh, great, thank you. I'll let my program director know.
All right, great question. Next question. Does anyone have another question? I know we're just right at time, but we'll open up for a question or two if somebody has a question they would like to ask the doctor. No one? All right.
And feel free to email me if you felt there was any questions that you didn't feel comfortable with asking or didn't want to be put in the spotlight. My email is available, so I'm pretty quickly responsive. So feel free to email me.
Yeah, and I will also, we'll send this out. I know Guillermo from the center will send this out by tomorrow with her contact information and the phone number. And then I do have the phone number that was just put in the chat. So we'll make sure that Dr. Antwiler has that as well. So thank you. And then this will go out. This is being recorded, obviously, as we know. It'll be edited, it'll be closed captioned, and then we will get it out within probably the next 7 to 10 days at the latest. And we will blast it out to everybody, as well as get it to all of our community partners to share it far and wide as well. So I think with that, I don't see anyone else with a final question. Dr. Antwiler, do you have any final thoughts?
No, I don't. I just want to let everyone know that we're here to provide support for addiction medicine, and please do not hesitate.
All right, fantastic. And thank you all for joining us and for a very a hard lecture, but a very great, or hard topic, I should say, a great lecture, but a very hard topic for many of us. So Doctor, thank you again for your passion and your commitment to this.
Yes, thank you so much. Really appreciate it.
Thank you for having me.
Bye, everyone. Thank you.
Have a great evening, everyone.
Thank you.